Hello, everyone. Welcome to the first webinar series for IdeaFast, where we're going to be talking about new ways of measuring fatigue and sleep disturbances in chronic diseases. So let's jump right into it. A few housekeeping rules before we start the webinar. The participants are going to be muted by default, and during the interactive parts of the webinar, we're going to be able to unmute participants who wish to comment. So please raise your hand and we can unmute you. At the same time, there is a Q&A facility provided by Teams. If you click on Q&A, you can also type your questions on the sidebar that pops up on the right side. This webinar will be recorded and shared publicly on the IdeaFast website, and we're going to be using an interactive tool called Mentimeter very soon for us to gather some feedback from the participants. And as I said before, participants can either raise their hand or submit a comment/question via chat. And we will also be sharing the transcript of this webinar soon via email. The agenda of the webinar today, we're going to start off with a short welcome and Mentimeter feedback session hosted by me, following which our speakers will then get into the various sections of the presentation and webinar, which I will introduce shortly. So let's get started with the Mentimeter. So let's see who we have on our participant panels, on our participant, let's say, pool today. So please answer which country you're joining us from. It seems we have a quite a diverse representation of countries here so far already. Perfect. Then it seems like we have Italy as the most represented country currently from the participants that have answered. If we go on to the next question, maybe Alexandra. We would like to ask you, which sector do you primarily work in and what is your area of expertise? For example, health professional or from industry or a particular research area, so on and so forth. I see that we also have quite a diverse representation from various areas. We have some patients, kinesiology, industry, scientists, psychology, healthcare, nonprofit, human-computer interface researcher as well. Great. Oh, and the patient and advocate, as posted in chat. Next question. So we'd also like to ask our participants before the webinar starts, are you familiar with the concept of digital endpoints, which will be the focus of a large part of our webinar? Don't worry if you're not. We are hoping to introduce the concept as well. So that is part of the purpose of this webinar in the first place. Okay, fantastic. Then I think that would conclude our questions for now, and I will jump back into the presentation part of the webinar. I would be very proud to hand it over to Dr. Fai to kick us off with the welcome and introduction.
Good afternoon, everyone. I'm just going to share my screen just to check that you can see it. Can you all see the screen, my presentation?
Yes, absolutely.
Oh, that's great. Well, first of all, thank you very much for joining the webinar. It is my pleasure to introduce to you about the IdeaFast project, where I'm going to explain. Oh, is it not moving? Ah, it is moving. Great. So there are two main project aims for this project. So one of those, by the way, I forgot to introduce you to you the idea fast what it stands for, but I think it is a very long word. So I'm going to hopefully in the project aim, I can actually tell you what it is all about. So one of the most important aim of the project is to define digital biomarker or endpoint so that we can measure fatigue and sleep problem in patients with immune-mediated inflammatory diseases, which is essentially a condition where we think the immune system are responsible for causing a number of different chronic illnesses, and I'll show you some example later. But also in neurodegenerative diseases such as Parkinson's disease and Huntington disease. And the aim is that ultimately we can use this digital biomarker to develop a new therapy, but also potentially in clinical practice. And then the second most important project aim is also that through this project, we will be creating a very large real-world digital data set that including both biophysiological, neurocognitive, behavioral, personal, environmental, and also socialization observations that together with comprehensive clinical data and also data analytic. So that should, we think, will support future research in the disease area and also drug development in a much broader sense. So we have, of course, we cannot study every single immune-mediated condition or every neurodegenerative disease. So we have picked 4 conditions and 2 neurodegenerative diseases as an exemplar disease. So, but we hope that the finding will be applicable to other immune-mediated diseases and also neurodegenerative diseases. So in the IMID, we study inflammatory bowel disease, Sjogren's syndrome, lupus, rheumatoid arthritis, and in neurodegenerative disease, we study Parkinson's disease and Huntington disease. So why do we initially pick fatigue and sleep problem being our topic of research in here? So I think one of the reasons I think I kind of summarize in this figure, in those conditions that we talk about, and also indeed in many other chronic diseases, perhaps we know that one of the most disabling symptoms patient with these chronic conditions is fatigue and poor sleep quality. So in this diagram, we can show you that these are very prevalent, i.e. very, very common among patients. And often they are not always associated with that disease severity. So clearly this is a very important unmet need. And indeed, not only from the patient perspective, these are really difficult problems for them to cope with. Actually, it's also a huge burden to the society and the general healthcare in general, because we know that fatigue and poor sleep would affect the activity of daily living for people. And because of that, they often sometimes affecting their ability to work and the sickness absences and sometimes even losing their job. And we know that it's causing a very poor health-related quality of life. And increasingly, there are also data suggest that chronic fatigue and chronic poor sleep can causing increasing mortality. That, of course, would directly translate into higher societal and healthcare cost, which is, of course, is very important. Now, so I'm going to go through some of these in more details in my next presentation, but essentially at the moment, the way that we are measuring fatigue and sleep problem is inadequate. So therefore, we need to find some additional solution to that. So one of the reasons that I hope that many of those of you who suffer from chronic fatigue in the webinar will know that this is a very phenomenon, very difficult to describe because in some way they are multifaceted involving different aspects, and also they can be very variable and unpredictable. So by answering a questionnaires, it can be difficult to capture all those characteristics. In fact, while I use these kind of questionnaire in my clinic routinely, often I have many patients putting a lot of comment on the questionnaire, so clearly indicating that the questionnaire does not really always, allow them to express their problem of fatigue. So similarly, there are similar problems associated with measuring sleep, although there are gold standard about measuring sleep properly in a sleep lab, but of course that involves people going to a dedicated unit away from home, and it's very expensive. And of course, it doesn't really able to capture the impact of poor sleep quality. Now, so we think that therefore the proposed digital biomarker may have added value because although primarily, of course, fatigue and sleep problem is a subjective symptoms, but a digital biomarker may able to provide additional measurement, both in terms of providing real world data. The digital devices and technology may allow us to assess this symptom in a more frequent manner, in a way that people don't need to fill a questionnaire. Hopefully they can just wear some technology and the data will be collected passively. And also I think we give also some objective data that I think many patients would find that it is very helpful, because often people would just say, well, this is just how you feel, may not be real, but actually we know that these are real, and I think it's about demonstrating that. And I think it's also potentially allowing us to capture the variability in a more accurate manner. Now, so what is the IdeaFast consortium? We can see that this is really a very involving a lot of different aspects, and therefore this consortium needing a lot of different expertise. So this is a large consortium. We have 46 and going to be 48 partner. So we're including partners that can provide us with all the different expertise. So such as, for example, we need the clinical expertise, we need the device expertise, we need the legal and data protection expertise. We need, of course, our patients, we need to our industry partner, drug developer, we need data scientists and all kinds of things to ensure the project is actually able to deliver what we're wanting to deliver. And of course, this is a European project. It's also important that we have a good representation of the European countries. So we're involving 15 European countries, and we have a budget of 42 million euro to develop this project. I think I already show you that. So these are just the logo of the consortium partners. So for those of you who representing an institution or your company, so hopefully these logos are all that you'll recognize. Now, so this is the current project timeline. We started back in November 2019. We already completed a feasibility study, and we also have discussed with the EMA on 2 occasions. We have one informal meeting at the beginning of the project, and we have one qualification advice meeting at the beginning of the clinical observation study. And we are currently about a third way through our clinical observation study. Our hope is that in the next 2 years or so, we can complete the clinical observational study, and then we can analyze the data and go back to the regulator to see whether the digital endpoint that we developed are potentially acceptable or useful for future drug development. Now, I've also been asked to give a brief introduction about what is the IMI initiative, or what it used to stand for is the Innovative Medicine Initiative. The name has now changed to Innovative Health Initiative. But essentially, this is a public-private partnership between the European Union and the European life science industry, because we know that in project like this, it is really important that there is close collaboration between the different stakeholders. So the main aim of the IMI or IHI project is about translating health research and innovation into benefit for the patient and society. And also through this, we can make sure that Europe remain the leading, world leading um, country or area to provide interdisciplinary, sustainable, patient-centric health research. So the funding are jointly funded by the EU and also the industry associated association, mainly pharmaceutical company, representing the European life science industry. So this is it. So thank you for your attention.
I will then hand it over to I think Isabel or Monique, and I think she can introduce Isabel, who might be the patient perspective presenting on impact.
Yes, thank you, Sean. Yeah, I asked Isabel, one of the patients that participated in the ID Fast, to give some introduction and a patient's perspective on fatigue in an IBD patient. So I can't see Isabel right now.
I am here.
Good to hear you.
I have my camera on. Are there others that can see me?
Yeah,
yes,
we can see you.
I can see you. Great. Yes. So here's Isabel.
Yes, I will take the word then. Hi everyone, my name is Isabel. I'm 20 years old and I have Crohn's disease. Right now I'm studying English at the Utrecht University, which is really nice. But okay. Oh, sorry, my Siri is going off. Excuse me. But I'm here to tell you a bit about the patient perspective on fatigue in chronic diseases. In my case, it will be inflammatory bowel disease, which is Crohn's disease in my case, but you also have ulcerative colitis. So 3.5 years ago, I was diagnosed with Crohn's disease, and it took me a really long road. I did have some symptoms with stomach pain, but my most common symptom was fatigue. And my doctor always said, no, you're just in your puberty. You're just having so much going on in your social life. It should be nothing. And I think fatigue is a really underrated part of chronic diseases, which should be looked at more. And that's why I was really thrilled to be part of this research project. And I was really glad that I could participate. So right now, I'm in remission. So my Crohn's disease is going stable, and I'm really glad, but I still have lots of issues with tiredness. I have some special agreements with the university that if I'm too tired, I don't have to go to my classes. If I can't make a test, there are some special provisions. I get some extra time. But also in my social life, it still affects me quite a bit because I have to, or at least I want to go to a lot of parties and I want to do fun stuff with my friends. But at the same time, it's not possible for me to do everything the same way they can because my energy levels are way lower, even though my Crohn's is in remission. And it could be because of medication, but it could also be because it's just a part of the disease, which is not all too familiar. And that's why I'm really glad this research is, happening. Um, so I really want to thank you all, and I'm not sure if there's anything more I can say about the fatigue. It's just it's a lot of impact, and I think there should be more research into it.
Yeah, thank you, Isabel. I think that your story is quite clear, and as you said, you're like a young patient in the bloom of your life, and yeah, sometimes you just can't do everything you want because of the fatigue. So it plays a huge role in the life of the young patient. So thank you for your story.
Yeah, definitely. And I think also it's not only me. I'm part of the IBD community here in the Netherlands. I am participating in a podcast, which I'm leading, which is really nice. And the first thing everyone says is how the fatigue impacts their life and how they are still, even when they are in remission, and not everyone is, of course, still feel so much tiredness and how they really want to join all of the activities, but they just really have to be in touch with their feelings about their tiredness and just really communicate with themselves, what can I do and what can I not do. So Yeah.
Yeah. Thank you.
Hi, everybody. Nice meeting you. I share my screen. Can you see it?
Yes, but we
Yep.
see the actual presentation.
Perfect. Okay, so I will just briefly introduce what are the common pathways and how common is fatigue and sleep in neurodegenerative diseases. So in general, just to give you a very, very short background, what is a neurodegenerative disease? Neurodegenerative disorders are an umbrella of different syndromes, always characterized by the accumulation of specific proteins in specific regions of the brain. And so we have a lot of different neurodegenerative disorders, and depending of the specific protein and the specific region of the brain, we have classified different kind of neurodegenerative disorders. And of course, all of them are defined also by different symptoms, which can be motor symptoms, cognitive symptoms, and others. In IDEAFAST, we included patients with Parkinson's disease and Huntington disease. They are both characterized by alteration of movement. Why that? Because we know that in Parkinson's disease specifically is a key issue is a neurodegeneration of the substantia nigra, which is a very, very small nuclei of our brain stem, so in the low part of the brain. And we know that these very, very peculiar and small neurodegeneration can lead to a decreased level of dopamine, and the decreased level of dopamine can lead in many years to different motor problems, mainly characterized by bradykinesia, so slowness of movement, and partially associated with other disturbances of gait and other non-motor symptoms, including also fatigue and sleep. And we know that the symptoms can start even before the motor syndromes, and we know that again there are a lot of no motor symptoms in Parkinson's disease, but also in Huntington disease, depending on the neurodegeneration pathway we have. So also if the neurodegeneration is very small, if there are some regions with mild neurodegeneration, we can have a different kind of symptoms, including gastrointestinal symptoms, olfactory loss, neuropsychiatric symptoms, and again also sleep disorders. And which are the key treatment for Parkinson's disease? Of course, is dopamine and a lot of different drug treatment with dopaminergic efficacy. But then a very, very important issue, and we have new data showing this, is that sport and motor activity together with physiotherapy is also very, very important during the whole course of the disease. And so, of course, we should know that the drug treatment is efficacious in most of patients, but the association with motor activation should be always considered. What about Huntington disease? Huntington disease is the most common genetic neurodegenerative disorder, and is characterized by a small mutation in a very, very important protein called huntingtin. And we know that this protein is very important for for different neurons, and particularly in neurons acting as activating neurons, again in this region called basal ganglia, which is just near the cortex, but is more involved in the complex movement alterations. And so usually most of patients are complaining about slight problems with movement and abnormal movements, which are defined as chorea. So they are slow movements, and at the beginning of the disease, they are not a big issue to be contrasted. But then, when the neurodegeneration is a bit more, then they can be a problem, of course, for the patients, because they can affect also the daily activities of the patients. And together with these movement problems, we can have other disorders beyond the movement disorders, including neuropsychiatric symptoms, language difficulties, and also fatigue, and in general slowness, and again, very, very common also sleep disorders. So what we know now from different studies and perspectives and longitudinal studies, basically based on questionnaires, is that fatigue is very, very common in Parkinson's disease, and even more in patients with Huntington disease. And again, I have the same impression of Phi, that fatigue, also in neurodegenerative disorders, is not can change over time, can change in the same day or in the different weeks. And of course, to have some instruments to evaluate fatigue also with a time lapse and in different periods of the time is very important to understand the pathophysiology and also what can we do against fatigue. And what about sleep? So in Parkinson's disease, is very, very new an association with specific REM sleep behavior disorders, which are affecting 20 to 40% of patients. And we know that the REM control of our sleep is basically driven by a very, very small nuclei near the substantia nigra. So to make the story short, the neurodegeneration lead to Parkinson's disease can also lead to a very specific alteration of sleep. But there are, during the course of the disease, there are also other sleep problems in Parkinson's disease, including insomnia, including also the sleepiness. And in Huntington disease, this association with REM sleep behavior disorder is less evident, but we have instead a lot of other problems, especially insomnia and difficulties with a lot of awakening periods. And also we don't have large studies evaluating this in a deeper way. And I'm sure that with IdeaFast we will understand a lot more about the sleep and fatigue disturbances in neurodegenerative disorders. So I'm also open to eventual question, but I will give my the word again to the moderator, because I think we can discuss after all the presentation in a very, very shared quick answer and session. So thanks again.
Monique, who will talk about them in terms of the immune-mediated diseases.
Yes, thank you, Sean, for the introduction. I'm going to share my screen as well. So I hope you can all see my screen. So as said, I'm going to talk about fatigue and sleep disturbances in patients with immune-mediated inflammatory diseases, also called IMIDs for short. And so first I would like to start with a general introduction on the IMIDs, and then talk a little bit on sleep disturbances, and then focus on understanding fatigue in IMIDs. So what are immune-mediated inflammatory diseases? This is a large group of diseases where, as Fai earlier said, the own immune system attacks mistakenly the healthy tissues of the body. And all these diseases are characterized by a relapsing and remitting disease course. So that means that patients can have a period with a lot of disease activity and a lot of complaints, and then they start treatment, and then the disease becomes less active, and that's the period that we call remission, when there's no sign of active inflammation. And all these diseases are treated a little bit likewise by suppressing the immune system, and this can be achieved by oral medication or by more heavier medications such as infusions or injections. And every IMiD has his own approach, his own treatment approach. We do not fully understand what the cause of the IMiDs are, but we do know that's a combination of factors such as a genetic predisposition and environmental factors. So on this slide, you can see the 4 IMiDs that are included in the IDFAST project, but there are many more immune-mediated inflammatory diseases. So on the left upper corner, you can see the Sjögren's syndrome. And in this case, the moisture-producing glands of the body are attacked. And this can cause things like a dry throat and a dry mouth, and dry eyes, but also a dry skin. On the left lower corner, you see systemic lupus erythematosus, also called short SLE. And in this case, multiple organs can be attacked, such as the kidneys, the lungs, the joints. And a common feature for this disease is the butterfly-shaped rash on the cheeks. And on the upper right corner, you see the rheumatoid arthritis. And these people suffer from swollen, red, and painful joints. So in this case, the joints are attacked. And on the lower right corner, you see the diseases that I'm most involved in are the inflammatory bowel diseases, so the IBD. And this consists of ulcerative colitis and Crohn's disease, and in both these diseases, the small intestines or the colon is attacked, and this causes diarrhea, abdominal pain, rectal bleeding. And in the case of ulcerative colitis, the colon is more affected, and in Crohn's disease, everything from the mouth to the anus can be involved.
Sorry, daar moet ik je het antwoord op schulden.
Also, my Siri is going to introduce itself. So the IMiDs are well recognized diseases worldwide. It has a high prevalence, and it's even getting higher. And as we said before, it's diagnosed in patients with a young age. So for SLA and inflammatory diseases, it's mostly diagnosed between 20 and 40 years. For Sjögren and rheumatoid arthritis, it's between 40 and 60 years. So as said earlier, it's really about young patients in the bloom of their life and want to do a lot of things, and then they have a really invalidating disease. And the sleep problems are common among people with IMiDs. As you can see, it differs a little bit between the diseases and varies from 50 to 75%. And you can imagine when you have like painful joints that you can't lie in bed that comfortable, or when you have diarrhea like 10 times in the night and you have to go out, to go to the toilet, then you can't sleep as well. So the complaints can also influence the sleep of the patients. And now I would like to focus more on fatigue. You can see that it's a little bit prevalent, as a similar prevalence between all these IMIDs. And it depends a little bit on the way you diagnose the fatigue. I said earlier, there are a lot of validated questionnaires to diagnose and monitor fatigue. So this makes it difficult to monitor and also to compare the results of all the studies that have been done so far. And the big question is if fatigue is a reflection of the ongoing activity of the underlying IMIDs. So we know that fatigue is more prevalent among the patients with the active disease. But the good news is that fatigue improves when you treat the underlying IMIDs. So a patient get less fatigue. But however, fatigue persists in a significant proportion of the patients with their IMIDs in remission. So not all patients who are fatigued and therapy started will the fatigue be improved by the treatment. And it's also possible that a patient have active disease and doesn't have any problems with sleep or fatigue. So yeah, it's not a it's not always that a patient with active disease is fatigued, but it's also not the case that a patient that is in remission has no fatigue. So it's really important to do more research on this. And on this slide, you see contributive factors to sleep and fatigue in IMID patients. So first, the lifestyle. We know that exercise, physical exercise, and stop smoking can improve the fatigue. Thereby, depression and anxiety can have an influence on how fatigued patients are. And as I said, the disease activity plays a role, and the pain and the complaints that make that you can't sleep that well. And it's even it's not only that these factors influence the fatigue, but these factors also influence each other, because when you are stressed, there's a chance that you have a more active disease when you're stressed. So this influence each other as well. And then we know that anemia is more common in chronic diseases. And for the inflammatory bowel diseases, you can imagine that when your intestine is attacked, that you can't take every nutrition very well. So there is a more nutrition deficiencies are more prevalent in patients with chronic diseases. And lastly, medication has also an influence on fatigue. For example, the anti-TNF therapies are associated with fatigue. We know that patients who use steroids, they have a more disturbed sleep. So medication also plays a big role. And fatigue is associated with many adverse health outcomes, as Fai said earlier. It's associated with a higher mortality, more hospitalizations, and as Isabel also mentioned, it's associated with disabilities in the activities of the daily living and limitation of physical functioning. And I think it's not important what we as healthcare professionals think about fatigue. The patient perspective is the most important thing. And patients think that it's the most burdensome, or it's the thing with the most negative impact on their daily lives. And I think it should be on the top research priorities, and it's of the top priorities in need of improvement. So sometimes you feel a little bit left alone in this symptom. And as Isabel also said, it plays a very big role in social activities. And this slide is also explained by Fai, but fatigue can lead to sickness, absence, and increased medical consultations, leading to an increase in the social and healthcare costs. So I hope that you now can understand that fatigue is a very complex symptom with a huge impact on the daily lives of the patients with IMIDs, and that's important to study the markers to measure fatigue, and that we have to use the devices to measure it, and that we also have to use these devices more easily in pharmaceutical trials, so that we not only see if a treatment is effective on getting the disease in remission, but it should also be used, the devices should also be used so you can see what the effective treatment is on fatigue. And I think with the ID-FAST project, we are certain that we can impact the future quality of life of our IMID patients. So thank you for your attention, and I want to hand it back to the moderator.
Great. Thank you very much, Monique. Now, if I believe that we have some time for questions, if we have any questions from participants.
There's a question from Singapore. As a member of EFCCA, can we be part of such a study? So Crohn's and Colitis Society of Singapore.
Thank you for your interest. Unfortunately, that is not possible at the moment because the study are run in the European country. We don't really have a study site in Singapore, I'm afraid. But hopefully, if the study is successful, I'm sure we'll be sharing our finding to other people as well.
It's a question to Isabel, and I saw, unfortunately, she left already, but probably Monique or maybe someone else can elaborate a little bit on her story, because, well, first of all, well appreciated to have this voice basically almost at the start of the session. I think that's very important to have with these kind of projects, to have the patient's voice central. And it's really good to hear, I mean, from the actual patient, what it means to have fatigue. What I was wondering is, also given the pictures that you showed on this variability of fatigue and in daily life, how would digital biomarkers actually help patients to better manage their disease? Is there also that perspective to it, or should I only see it as, okay, it helps the healthcare professional to better treat disease, or it helps clinical development to develop better drugs that ought to also address fatigue, or is there also a self-management aspect to it?
Thank you, Willem, for your question. I think it can help in multiple ways. First, if we identify these devices as good markers for fatigue, we can use them easily in further research, as I mentioned. And sometimes patients think like they can say I'm fatigued, but they feel that they are a little bit left alone, and that no one believes them that they are really fatigued. And if we have these digital markers, then you can see like, oh, something changed in the activities, and if there is an objective marker, sometimes a patient can feel them a little bit more heard. Then they have more a voice, and that they have an objective marker for the fatigue. And maybe I'm just talking in very future perspectives. We can also monitor it better, and we can adapt the therapies on it. But then we should also know that adapting the therapies is effective to improve the fatigue or not. So I think it's just, in the IBD world, it's a really great first step in further research. And maybe if I can add something as well.
Yeah, so thank you, Monique, and thank you, William. I really like your idea. In fact, that would be one of the things that I was thinking when I present, although this project, of course, have a very focused objective to get to the digital endpoint for regulatory perspective. But as I said, I think we also hope that it would have some clinical use. And your suggestion is really great. So I think if we do identify something that is reliable, So you could, I think we will need to work with patient. Well, sorry, I assume you're one of a sufferer, people with the condition, like yourself, to work out some self-management program or work with clinician, because sometimes I could imagine, although, I'm fortunate enough, I don't actually suffer from any of these conditions, but listening to a lot of the people, sometime about the activity management, sometime actually, let's say if our device can tell you, now you're really getting quite fatigued, you need to take some action, that may allow you to plan your activity better potentially. But of course, that would have to be very individualized. I guess, ultimately, you have to live your own life. You have other ways. You need to prioritize your own thing. But I think the digital devices, the marker may give you the information to allow you to plan it potentially. And also, if you can see your pattern, maybe you can work it out, because a lot of these really, I think in our day-to-day clinical practice, we know that everyone is different. So I think we're hoping that because the digital technology allow us to potentially have a continuous monitoring really, isn't it? Because the questionnaire you have to fill out every time, right? But if this is really useful, then you can use the technology all the time, and this can give you feedback, and so potentially that would be that use as well. But we're obviously not at that stage at the moment, but in the future, hopefully that could be something we can achieve. But thank you for your suggestion.
Yeah, I just noted a question in Italian, so I just answer in English, but I will explain this also in a very, very short way in Italian. So the question is, how important is physical activity for sleep disturbances and fatigue? And is possible to impact of Parkinson progression with a physical activity? And so my answer, or the general answer, is of course is very, very important physical activity, and there are several studies showing that it can impact and it can ameliorate sleep disturbances as well as fatigue. We still do not know exactly which kind of sport and physical activity is the best way to act with for fatigue and sleep, but physical activity is core now also for the long-term progression of Parkinson's disease. So we know that the physical activity is very, very important for lowering the risk of progression of Parkinson's disease. And I think I will chat with Maurizio directly to give a direct answer after.
I think there is a question from somebody representing colitis and Crohn's UK. I can briefly, is that okay if I briefly answer that? Although
Yes,
I noticed
absolutely.
that Alexandra already suggests, would that be Mikhail? Sorry, I don't know, may not pronounce your name properly. So there are a number of ways. So first of all, this study is currently recruiting in the UK, and we have a number of sites. So it would be really helpful if Crohn's and Colitis UK can potentially advertise the study, so that more people in the UK who suffer from IBD to be aware of the study. I can let you know more about the recruiting site in the UK, and of course we can also discuss many other ways that we can collaborate, because one of the things that we have not time to mention is that this project is always about the patient. So we have a lot of activity involving the patient group. So we have a patient involvement and engagement group. So we really want to welcome patient organization joining, whether providing their expert input, providing things on dissemination, or even financial support. There are lots of ways that you can help. So maybe we can arrange a separate meeting if that's okay. But thank you for your interest.
Thank you very much. I think we had a question from, it was Lee, who says that they were designing a study using wearables and neurables to characterize sleep in their participants. Do you have any advice on how best to determine the duration of measure needed for validity and reliability of these digital biomarkers?
I think this is also a question for Fai. It may be a bit outside of the scope of today's webinar, which is giving just a general presentation. However, we will follow up with some webinars that may be more technical and more appropriate. You can always contact us via the website for more information, and we can actually link you to our responsible partners in the project. So thank you for that question.
I'm going to share another presentation now. Is that the right one? Are you seeing my presentation now? So you should show digital biomarker of fatigue concept and approach. Okay, so well, welcome back after the Q&A session. So this next talk is about our general concept and approach. Of course, we are going to talk about it in a more general sense. So let's go back into thinking. My presentation probably more focusing on fatigue rather than sleep. Otherwise, the presentation will be very long, and also in part because fatigue is really more my expertise than sleep problem. Now, so first of all, I think when we're trying to study fatigue, one of the problem, although we all recognize that fatigue itself is a big problem, but really at the moment there is no real consensus definition. So exactly what fatigue is can mean potentially different things. We also know that fatigue is common in many, I already mentioned both rheumatic, sorry, I'm a rheumatologist, but also non-rheumatic chronic diseases. Now, but one thing that I think we would agree amongst both the people with these chronic diseases and all the clinician and researcher is that the fatigue experience by patients with chronic diseases seems to be different from otherwise healthy people. We all have time that we feel a bit tired and fatigued. And if you're thinking about all the qualitative research study, probably the key characteristics that are different between fatigue in chronic conditions and healthy individuals seems to be the unpredictability. So people can sometimes suddenly just feel so fatigued. There are patients who talk to me to say sometimes they just need to stop the car driving because they just couldn't carry on. They just need to stop and have a rest. And they're so variable. So some days they may be fine, and some days they are just so feeling so fatigued. And also in general, when they do have the fatigue, it seems to be extremely profound, which means it's really, really disabling. They really have to stop and they can't do a lot of things. And also the other thing is that unlike healthy individuals who are fatigued, normally after they rested, they will feel better. But for some reason, fatigue in chronic diseases doesn't seem to be improved by rest. So I would say that those are the four key differences between fatigue in chronic diseases and in healthy individual. Then I guess the next question that we often think about is that although we learn about that so many fatigue is happening in so many chronic diseases, are they the same in let's say fatigue in IBD or fatigue in rheumatoid arthritis or fatigue in Parkinson's disease? And then the other thing is often that fatigue can sometimes be, people think about, could it be more kind of mental fatigue, i.e. people can't concentrate or can't think clearly, or are they different from the physical fatigue, which means that they can't really do things, they can't get out of the chair, they can't go for a run, or are they actually, they're all fatigued, but it's just that you have a different dimension or different aspect? Because in general, I would say that I don't come across patients who only just have mental fatigue or just have physical fatigue. They're usually a mixture of both, but then they would have a slightly different level of severity. But of course, this is something that we don't know for sure yet. So from our perspective, so I've been looking at fatigue research for a number of years. So the way that I see it, although the way that I define fatigue maybe, it is a multi-dimensional phenomenon in which there are changes in physiological, cognitive, motivational, and also emotional state of the body. In a way that they're resulting in an impairment of an individual's ability to function in their normal capacity. So I think that would be a reasonable definition to start with in addressing the problem. Now, so then the next question is that although we now maybe, let's say we stick with this definition, how do we measure it? It's still going to be very challenging. So I already mentioned in research, typically fatigue is defined basically by the fatigue questionnaire that they use. And then at the moment, there are a huge number of different fatigue questionnaires, at least 50 or more, we know that. And they often ask between the patient to have a certain recall period, i.e., over the last 1 week or last 4 weeks, how they are feeling. But even if in study using the same questionnaire, often there is no standardized cutoff value. So it's not like if you use the same questionnaire, you will say a score of 5 is fatigue, a score of 4 is not. It's often vary between a study, vary between design, etc. So it's making it very difficult to compare. And then, of course, fatigue ultimately is more than just a symptom. It's also about the impact, isn't it? We heard, the amazing story about Isabel. We talk about, is how is impact on it. So it may not just about the fatigue severity. So do we actually looking at the severity alone, or do we measure the impact, or do we do both? And then the next things we think about is actually how often are we going to do this questionnaire? Do we need to do it every day, every week, every month? And again, there's no standard guidelines at the moment. And of course, in terms of the burden on the participant, that would be a huge thing if people have to do a questionnaire every day, for example. And then the other question is, do we need to use a different questionnaire for each of the diseases? So again, that would actually have an impact on how useful anything that we develop, because if we have to develop, something for each diseases, there's so many different chronic diseases, there's a huge amount of research effort into developing a different questionnaire for each diseases, and they may or may not be necessary. Now, so again, I think Monique kind of briefly showed a very similar figure on the factor. Now, although we can't say for sure that the fatigue in different chronic diseases are the same, but we do know that a lot of the factor that seems to be associated or predict fatigue and disturb sleep across different chronic diseases seems to be very similar. So, for example, there may be changes in the circadian rhythm or even sleep disorder. We talk about, mood changes and pain. There seems to be changes in the immune dysregulation, in the hypopituitary adrenal axis. There may be symptom of autonomic dysfunction. There are changes in the central nervous system. There may be changes in the cardiovascular or respiratory fitness and muscle weaknesses. There are also some changes in various metabolic and neurotransmitter pathway. So there is a strong possibility that at least there's some shared common pathogenesis or some pathway between different conditions leading to fatigue and disturbed sleep. And in fact, we know that for diseases where we do develop a disease-specific questionnaire, they often really relate very well to a more generic fatigue questionnaire. So I think we think that actually there is a strong possibility that we would be able to identify some useful fatigue biomarker that can be used across all diseases. So that's one of the theory that we think can be pursued. Now, there are other challenges in measuring fatigue, as I mentioned some of those earlier. So fatigue is a multidimensional, so we need to think about all the different impact and severity, but also about the variability. We need to think about, do we measure it at the moment, or do we want to measure a mean over a period of time? We need to take into potential confounder, i.e. other potential factor that may influence the fatigue. And then, of course, we need to think about the balance between based on a subjective assessment, i.e. like a questionnaire, or do we use an observed or objective measure, for example, using digital technology. Now, so this is just some illustration about how we think the digital biomarker may help. Now, so this is a very common fatigue questionnaire that people use in research called the fatigue severity scale. Now, there are 9 questions in here, so the participant would be asked to score over the last week, how did they find about, in response to that. Now, if you look at the 9 questions, apart from question 1, who asked about motivation, the rest is really more focusing on the physical functioning aspect of fatigue. So if somebody having a lot of the mental aspect of fatigue, this questionnaire can potentially underestimating those, fatigue level. Now, and then the other thing is, I already mentioned, all these questionnaires may have a different recall period. It's difficult to know whether you choose 1 week is the right one or 4 or 5 week would be the right one. So sometimes then if you have a digital measurement, you can choose the period you want to monitor, as you need. And then, of course, if you're looking at that, the patient, we need to decide how do they talk about the last week? Do they give the answer on the worst possible one, or is that the average, or the most recent one? They may recall what happened, in the day before, then exactly 7 days before as well. And then some of these things like, for example, exercise can bring on fatigue. We know that by using certain digital technology, we may be able to more reliably and objectively measuring this rather than answering a questionnaire on a scale of 1 to 7. And then in some of these questions, for example, asking about fatigue, would be the most disabling symptom or interfere with the work and family and social life. It's difficult sometimes to tease out, is it the fatigue or is it, some other factor to influence that? This kind of question is just not very reliably to work out, whether this is the fatigue causing this problem. Now, similarly, another very commonly used fatigue questionnaire is the Modified Fatigue Impact Scale. That again shows some of those examples which we think that digital technology can help. So, for example, the first question about asking the participant whether they have been less alert. We know that there's some well-validated neuropsychological tests. In this case, for example, psychomotor vigilance test is exactly testing the alertness. And similarly, about attention and ability to pay attention, there are again similar tests. For example, using digital symbol substitution test would be a very good way of objectively measuring this. And then, like the question about they have to pace themselves in physical activity, we know that we can using accelerometer like Fitbit and thing, we can actually see whether people are actually pacing their physical activity. So again, that would give us a very objective measurement of those. And then about the question about able to maintain physical effort for a long period of time, again, we can actually use digital technology to keep track on the heart rate and respiratory rate. We can work out the aerobic capacity. So we can actually see whether they can maintain that physical effort for how long a period of time. And similarly, in the case of sleep problem, so typically one of the very common questionnaire to measure the impact of sleep is using an Epworth Sleepiness Scale. But again, whether how much time they're dozing off while sitting and reading. Again, we can use a combination of activity tracker and a physiological tracker. We can see whether they are actually sitting down and dozing off. So again, this will allow us to actually keeping track on those things much more accurately and using a questionnaire. Now, so indeed, there are some study who kind of able to give us some preliminary data to say that these potentially be possible. So, for example, this is a study done by a group in America, almost 10 years ago now, looking at some of the neuropsychological tests that I mentioned and their relationship with self-reported mental fatigue. Now, I'm not going to go through all the little figure, but essentially what they find is that they have found a couple of tests that seems to be correlate to the self-reported level of mental fatigue. And if they take into account of all the other potential confounding effect, they still find that one of the tests seems to be correlating very well with the self-reported mental fatigue score. And indeed, we have done an early phase clinical trial with one of the pharmaceutical company who developed a new drug for Sjogren. We showed that if this new drug, that only in a phase 2 trial, of course, we showed that they were able to improve the mental fatigue, but at the same time, we can also demonstrate that those people who have the active drug actually improving their performance in doing the digital substitution test that I mentioned. In other words, their ability to pay attention has significantly improved, whereas the people who are receiving the placebo drug, i.e. the dummy drug, have no impact on their objective measurement of their attention. And also, we have done other pilot studies. So in our own research institute, we have been using a digital physiological tracker together with an activity tracker, and we use a combination of feature engineering and also artificial intelligence. We were able to find some, using some deep learning, we were able to find the digital parameter correlate to self-reported fatigue score in patients with Sjogren syndrome quite well. So that's also then lead to this much bigger IdeaFast project. Now, so in this IdeaFast project, we follow a kind of a generally recommended approach in developing biomarkers and digital endpoint. So we already talk about, we clearly have very strong evidence to say that fatigue and sleep is one of the very important aspect of health that we need to look into. We identify 4 what we call concept of interest that we can measure using digital technology. And then we now identify a number of digital devices and technology. Unfortunately, we cannot tell you exactly what they are because the studies are still ongoing. So clearly there's confidentiality issue about that. So if you are going to ask me about the exact COI or the devices, I'm afraid I can't give you the answer for that. And so far we have interact with the European Medicine Agency. So they basically say that the way that we're approaching the problem, they agree with that. They obviously also have other question and advice for us to do that. So at the moment we are in the middle of completing the clinical observation study, which my colleague Professor Messner are going to tell you a little bit more about the COS later. And hopefully by the end of the project, we will be able to analyze the data, and hopefully we'll be having some promising digital biomarker that we can take back to the EMA to see whether they agree with us to move forward to test them in a more formal testing. Oops, oh sorry, I forgot that of course our work were informed by a very large group of clinical knowledge and insight task force, including clinicians, scientists and patients to come up with these ideas. So thank you for your attention. So this is the end of my presentation.
Jen had a question previously at the end of the last presentation. Her question was, in discussing these concepts of measuring fatigue in patients with chronic diseases, are there patients who are using objective digital data to better communicate with clinicians or family members about their fatigue? And if so, how do they use that digital data?
I think it's just similar to my answer to William earlier. I think at the moment, obviously, we are still developing the project, so we haven't actually identified any digital endpoint or marker for fatigue yet. But hopefully, yes, in the future, if we can, validate it and we can show that yes, we certainly would love to work with our patient partner again to see how we can use this to improve our day-to-day clinical practice, communication with clinician, etc. But I don't think it will going to take a few more years for us to get to that point, I'm afraid.
Thank you very much for giving me the opportunity to present. I hope you see my slides. This seems to be the case. Otherwise, please raise your hands, which I honestly do not see. So yes, I'm happy to present a little bit organizational aspects of this IDFAST project. And what you see here on the left side is the start of the entire IDFAST project, and at the right side, the end of the planned end of the IDFAST project. And this is a huge project. And what you see here in the right and the left part of the slide is the first part of our study, where we had a preparation phase for a feasibility study and then a feasibility study. So to see whether handling all these multiple devices is really feasible and accepted by the participants. We included about 150 people, and basically what we get out of this study is that it is feasible and people accept that they wear more than one device, handle more than one device during a certain period of time, also in the home environment, which is good news. So this is also important for many of the people that organize trials, also important for participants and also for us as patients, that we understand that this is something what we can handle, all of these gadgets and devices that collect information about our physiological behavior, about our mobility, etc. Then we moved into a clinical observation study phase, and then where we are now is the clinical observation study. You see here, this is the timeline with months mentioned here, and where we are now, and I'm talking about the clinical observation study, and in June 2023 we are here, so about almost half of the clinical observation study. So the objective of this large study is basically, so we have a few more objectives, but this is, I think, the most important one: identify and evaluate digital parameters of fatigue, sleep quality, and daytime sleepiness that reflect daily self-reported measures. And how do we do that? I will show that in a minute. Here you have an overview of the planned sample size of the study. This is 2000. And here the different cohorts we are recruiting, and that have already been mentioned a few times: Parkinson's disease, healthy volunteers, Sjögren, Huntington's, inflammatory bowel, systemic lupus erythematosus, and rheumatoid arthritis. And what you see here in the green column is the numbers we plan to recruit, and in the blue column you see the numbers we have already recruited, here also mentioned as percentage of total. The study design, if you participate in the study, looks as follows. You have to be involved in the study for about 24 weeks. And we start with the clinical visit, and we end up with the clinical visit. And in between, so that we have a visit every 8 weeks, is a home visit, and so a virtual remote visit. And this is visit 2 and visit 3, both are remotely. And what you see here, this is a light red box and a dark blue, dark red box that stands for a technology introduction period. That is for 3 days at the beginning, so people get used to the devices they have to wear. Then for 1 week, we call this the technology use period, and technology use period is the heart of the study. That is 1 week after or before each visit, where we collect home-based data for many, many different aspects of human physiology, mobility, and human behavior. What happens during the visits? In the hospital and at home, we assess general and disease-specific aspects of the diseases and of demographics based on clinical evaluation, same based on self-reported evaluation using questionnaires. That also covers, of course, fatigue and sleep aspects, but also other aspects that are covariables for our analyses, for example, health-related quality of life and other aspects. We will collect also biological samples, at least in a sub-study, a sub-part of the study, and the visits are also used, especially the first visit, to introduce people to the use of the digital technologies, which is not super simple, but it is possible. And we also include, of course, a user acceptability assessment, which is central to the understanding of how this can be implemented also in clinical routine, maybe at the end of the day, and especially also in clinical trials. We include also assessment of the severity of fatigue, so that we can use this data set then also to detect aspects such as minimal clinical detectable change. So people use smartphones, also their own smartphone if they want, and also other digital devices during the technology use period. And with the smartphone, we assess a couple of parameters. We do that, for example, with the help of a diary to understand how was the sleep of the participant, how was my sleep, how was my fatigue during the parts of the day. This is assessed for 3 times per day. People do also a cognitive task once per day on the smartphone. Then passively, the following aspects are assessed: typing on the smartphone, then also which apps are used, if people agree, and also we can do a geolocation so that we know where people were, and we can assess this on a relative manner. So we do not exactly know where people are, but we can produce a pattern of mobility. In subcohorts, we do collect additional aspects, for example, activities of daily life and assessment of specific symptoms. We use additional devices such as a mobile electrocardiogram, mobile movement sensors, a bed sensor that is put under the mattress, and that is not yet entirely clear, but we also tried to use a mobile sleep EEG in the subcohort. Basically, we assess with these devices in a passive way body physiology, mobility, and behavior based on heart rate variability, and mobility aspects. We can assess mobility in quantitative manners, but also we can assess the quality of the movement, and we can measure at least a surrogate of sleep phases and also wake sleep changes. When we have the data collected, then we have databases. We have an ECRF system where we put in all the clinical data. It is also digitalized. This data is then moved into the IDFAST platform. On the other side, the device data is collected and the raw data is then analyzed basically with device software provided by the companies of those who produce the devices. That is then further moved also into the IDFAST platform and also the process device data. And the IDFAST platform is accessible then also for our analysts to develop and use their algorithms and to reach our primary, secondary, and exploratory objectives. Thank you for your attention.
I will then hand it over to another patient who participated in the study and to Andrea to facilitate that.
Hi, so hi again. We have so thanks again for the opportunity to have a patient here. So please, so you can.
Good morning. Anzi, good afternoon. My name is Massimo Patelli. I am 66 years old and I am a teacher of chemistry and biology. I am suffering from Parkinson's disease for about 12 years. I have been in care for 5 years by Dr. Pinotto at the unit of neurology of the Ospedale Civile di Brescia. About 6 months ago, I was involved by Dr. Pilotto in the initiative you talked about. I was monitored for 24 hours a day for a week with sensors placed on the chest of the left and on the end of the spine. My commitment also included filling out questionnaire as well as the execution of some exercise 3 times a day via mobile phone. I was a little resistant at first, but then I gladly accepted because I think that scientific research also needs collaboration of the patients who make themselves available to researchers for the common group, and if then at the end of all the medical and world will be able to find a way to defeat these diseases. I will be eternally grateful. Pardon, excuse me for English, but this is.
Thank you very, very much.
We are also curious to understand from you if you have learned something new in the webinar today. So you could also maybe tell us in the chat whether the concept of digital endpoints is a bit clear for you, because we have seen in the Menti session in the beginning of the webinar that half of the responders actually were not aware. So we do hope that you've learned something today, and also about other curiosities about IdeaFast. That would be tremendously helpful for us as well. We have a question in the chat. So Niti, a significant proportion of patients are living with more than one chronic illness. So yes, a digital endpoint makes more sense than just a questionnaire. Yeah, I'm also curious. So what's our stance on composite digital endpoints that can capture more fatigue dimensions?
Well, I guess Yes, I guess we hope so. I mean, in some way, I think the questionnaire can also be multidimensional. There are indeed some multidimensional fatigue questionnaires as well. So as I said in earlier, we are not saying that the digital endpoint would completely replacing the questionnaire because ultimately fatigue is still a symptom. But I think the objective measurement can add value to the questionnaire in the way that I lay out in the talk. So firstly, it can be captured throughout continuously, or at least in theory. And then I think it would be really helpful for capturing the differences. And because it's captured continuously, then I think we don't need to like in a questionnaire you are fixed about asking a particular recall period, which sometimes can be restricted depending on there's a lot of things that the digital biomarker can help that the questionnaire would be difficult to achieve. But essentially that's one of the reasons really.
So there's another question posted in the chat from Jen. Similarly, when interacting with regulators and defining a context of use and a specific patient population for a digital endpoint, how has your group dealt with individuals living with multiple chronic diseases?
Good question. Actually, that hasn't came up, if I'm honest. But I think what it was very good is that they at least accepted our attempt to develop a cross-disease fatigue biomarker. So I guess I would argue that if that approach is acceptable to the regulator, then if you can use it across different diseases, there's no reason why, if they have more than one chronic diseases, that would not be applicable. But that particular point was not raised by the scientific advice committee. Anything else?
Great. Nidhi says that Lancet has a paper that 35% of the general population is living with more than one chronic condition.
Yeah, exactly. So in fact, I mean, that is actually a very good point. I mean, to be honest, I think even if you're going to develop something for a specific disease, as Nidhi has pointed out, there are very few people who have just one disease anyway. So, so you might as well go for that's actually, I think, is an interesting. Yes, of course, that's I think is very interesting. Thank you for sharing that.
I see Jen has raised her hand. Maybe we can unmute and allow her to speak. Okay, I think you can unmute yourself, Jen, now.
Thank you so much, and thank you for your presentations today. I've learned a lot. I'm curious in the context of sort of developing these measures of fatigue and potentially focusing on aspects of life that are related to physical behaviors. In some of the conditions that you're including, there are substantial movement disorders and things that occur that would impact the ability to measure physical behaviors with wearable sensors like actigraphy sensors. So I'm wondering how you're approaching these digital biomarker development across conditions that have different movement patterns, if that makes sense.
Yeah, it certainly makes sense. I mean, I will start with answering this, and I'm sure both Andreas and Walter may have something to add. And that, of course, getting quite technical side of thing. I think, firstly, there are a number of ways that we potentially can tackle it. Firstly, I think for a lot of these parameters, there are likely to be a huge amount of individual variation. So really, what we are looking for is actually it's more important to look at intra-individual changes, because you can imagine, I think, each person's the baseline, let's say, physical activity level, and would be different anyway. And I think to try to get an individual marker can potentially be challenging in that sense anyway. So to some extent, assuming so that may potentially be one way of dealing with this problem, because I assume that we can assume that people who've got movement disorder, they continue their movement disorder, but there are other changes that we can detect. And there, of course, even within the physical activity, there are certain parameters that are not just about movement dependent. There may be other parameters we could look at as well. But I don't know whether, and also I think the other thing that we are thinking about composite is also we wanting to take it into context, not just a single parameter, but actually in the context of other things as well. But I don't know whether Andreas and Walter have anything else you want to add to that.
Yeah, thank you, Mafai. So I have almost the same ideas. So, but I think it's a very, very key question, and is very innovative, the project, also because we will try to find out an answer. So we are always very focused on disease specific markers, and as you said, the general population has a lot of different markers, and also for regulators it's easier, or it will be easier, to have just one composite or one marker. So we will find for sure a solution for adjusting for the different diseases, and I completely agree that fatigue and sleep are related to mobility, and the mobility is related to the disease, but we will focus our attention on the changes in fatigue and sleep, and this can be independent, but also just partially dependent on the mobility, disease-specific mobility. But again, I think this is a very added value of IdeaFast, is to put together different minds, condition, and different also way of evaluating patients with completely different conditions to find out common digital markers, and the combination of non-mobility digital markers is also very innovative, for example, for Parkinson and Huntington, and this can be an added value compared to other studies just focus on mobility.
There's a comment slash question on the role of family members in helping collect with data.
I think that is best to be addressed by Andrea and Walter, because I think generally speaking, in the rheumatic and IBD population, that is not usually as much of an issue.
So this is also a very interesting question, and in a subset of patients, we are indeed evaluating both the caregiver and the patients, because sometimes they have indeed a different way of evaluating the same symptoms, and so in the future, I think to evaluate also PD and so in general, patients with neurodegenerative disorders with a caregiver, also with digital markers in an app or a digital question during the day is very informative, especially if there are changes in cognition or in confusion or in the general mobility. And so we are approaching this in a subset of patients at the moment.
I don't see any more raised hands or any more questions in the chat. If no one else has anything to add, I would suggest perhaps that we close a little bit earlier. Thank you so much for all your time. A huge thank you to all our participants and the fruitful discussion, and a double thank you to all our patients and the speakers following them for sharing their experiences.
Well, thank you all for attending. It's been nice to meet you all.
Thank you. Have a nice day.
Yeah, you all have a nice day. Take care. Bye-bye.
Thank you,
Bye,
everyone.
everyone.
Bye.
Bye.
Again, bye.